Hi, this is Dr. Gundusky. I'm going to talk right now about what a knee replacement is. Knee replacement is one of the most common surgeries in America, and you probably know somebody who's had a knee replacement. I'm going to teach you a little bit about what it is. Okay, this is a knee replacement. So this is a knee. The knee from the side bends back and forth like a hinge. It's a hinge joint, and it bends back and forth. So this is the knee from the front. So in a replaced joint, we have replaced the ends of the bones, which have bone-on-bone contact with the replacement parts. So in a knee replacement, here is the femur. Cap goes on the end of the femur, and then a flat piece of metal goes on top of the tibia, piece of plastic in the middle, and so no more bone-on-bone contact. That joint is totally replaced. So this is a total knee replacement, and that is what is happening. And so again, it still moves like a knee joint, still acts like a knee joint, still balanced by the ligaments on the side of the knee joint, but no more bone-on-bone contact. That's a total knee replacement. So I'm going to teach you a little bit more about knee replacement, and in other talks I talk about what sources of knee pain can be, what the treatment options outside of replacement for knee pain is, and then what the surgery itself is like. So let's talk a little bit about the knee joint, some knee anatomy, some more images of what knee replacement is. Okay, so location is important in the knee. Usually patients that have pain around the knee itself have a knee source as opposed to other locations. For instance, like the patients with pain around the hip joint often have problems that can come from the back or other issues that are not the hip joint. But around the knee, for the most part, most of the conditions around the knee itself are related to the knee joint. And so we'll focus on diagnoses there and trying to figure out what's going on. So again, the knee joint is made up of the femur on the top, the tibia on the bottom, and the kneecap or the patella in the front. In that model I just showed you, there was no kneecap, but that kneecap is in the front of the knee. And just like in all joints, on the bottom of the femur and the top of the tibia and the back side of the kneecap, there is cartilage. That cartilage you're born with, and when it goes away, that's arthritis. And when it is arthritic and completely gone, it can cause a lot of pain. The arthritis in this model is shown by that white stuff on the ends of the bones. So this is looking at the knee from the side. So on the ends of the bones is that white cartilage. Again, that's nice and slick and smooth, and it does not grow back and can eventually uh, get destroyed and cause severe pain. So this is a healthy joint. This is a joint with osteoarthritis. So healthy joint, that blue stuff is cartilage. The surrounding tissue around the bones is the capsule of the joint. And inside there, that darker blue is the joint fluid. So in a normal knee, and really most joints in your body are encapsulated. So that capsule holds the joint fluid in. The joint fluid bathes the cartilage, and that light blue cartilage keeps the bones from rubbing against each other. The cartilage is incredibly slick and smooth. I liken it to Teflon coating on a pan, and when it's gone, it's gone. That's what osteoarthritis is. Osteoarthritis is wear and tear type arthritis, where over time the cartilage wears out. And then when that wears out, it creates deformity, angulation, swelling, pain, and is not fun. And that's what will cause you to not like your knee very much sometimes. This is what x-rays look like when somebody has a knee issue. So this is the knee joint where you look at it from the front, and then on an x-ray you can see space between the femur and the tibia. This is a normal knee. So when you have space between the femur and the tibia on a weight-bearing x-ray, that means you have cartilage there. Cartilage you cannot see on an x-ray. And so if you see space between the bones, that's what is happening, is the cartilage on a weight-bearing x-ray is separating the bones, and therefore you know the patient has good cartilage. Looking at the knee from the side, this is the femur, the tibia, and then now you can see that kneecap in the front of the knee. That's the knee joint, and that's what it looks like from the side. So in a healthy knee, you have good cartilage space. So right where that red arrow is on a weight-bearing x-rays, again, you have a lot of space between the femur and the tibia. That's a normal knee. In mild arthritis in the middle, you can see a little bit of decrease in that space. And then in severe arthritis, you can see bone-on-bone contact. So this is a patient who's bow-legged. Their femur and their tibia are touching on the inside aspect. There's no more cartilage when they weight bear, and that bone is rubbing against the bone between the femur and the tibia. That's severe arthritis of the inside aspect of the knee. And that's what a very common x-ray for people to have. Pain in an arthritic knee is caused by the raw bone ends rubbing against and over one another with friction, which causes pain and inflammation. Knee replacement basically resurfaces the end of the knee joint bones to eliminate this. On the left of the slide is an x-ray of a knee replacement. From the front, you see metal pieces on the femur and tibia, and from the side or lateral view, you see that essentially a metal cap is placed on the end of the femur and a metal tray is placed on top of the tibia to resurface the joint. That's in that model I showed you. That's what we are doing with a knee replacement. And this is that model I showed again with the cap on the end of the femur, piece of metal on top of the tibia and plastic in the middle. Let's talk a little bit about the partial and total knee replacement. um, here's some images. Oh, sorry, let me go back to that. Here's some images of a replacement, partial knee replacement versus total. So if you have isolated arthritis on just one part of the knee. Sometimes you can replace just that part of the knee. That's called a partial knee replacement, and that resurfaces just part of the knee joint, not the entire knee joint that you would do with a total knee replacement. So you can see on this patient, on the partial knee replacement part of the slide, where it says knee with arthritis, that patient has some narrow joint space between the femur and the tibia on the inside aspect of the knee only, but the outside aspect of the knee looks okay. So that's a very common x-ray to see in somebody who has arthritis just on the inside. When that happens, you can replace the ends of the bones with metal and plastic in the middle, replacing just the inside aspect of the knee. Partial knee replacement in general is a little bit less invasive. There's smaller parts we're putting in, so incisions are smaller. It's a little bit easier recovery, and it's really a nice option for certain patient groups. But there's a lot of pros and cons to think about, well, which we will do in the office in terms of thinking about your age, your activity level, your bone quality, your x-rays, your arthritis locations, and all these things really factor into the discussion about partial or total knee replacement. But I do a lot of partial knee replacements. They're great surgeries for the right patient, but you do have to put a lot of thought into what's best for people in regard to these surgeries. Total knee replacement, which is a little more common than partial knee replacement, is pictured on the right, and that's what we talked about before, replacing the entirety of the knee joint, all three parts, including the kneecap, the femur, and the tibia. Let's talk a little bit about the implant of a knee replacement. So you can see that model that's moving on the left there. That is a knee replacement moving like I was kind of moving that model before, flexing back and forth. The kneecap is moving back and forth in front of the femur, and then the femur is moving on top of the tibia. So that's that model kind of blown up. And so basically the knee still acts like a hinge joint, still acts like a normal joint. We want it to move the same way. We want it to be balanced the same way. But we just do not want to have the patient have that bone-on-bone contact. And so that replacement, those parts between the bones, is what prevents that from happening. These are the different parts of the knee. So if we look at these different things, what's not shown is the kneecap in the front. So that yellow dot signifies the kneecap. That's in the front of the knee, and that rides back and forth in the groove of the femur. That's there. And then if you look at the light green arrow on the top, that's what's called a femoral component. That's the piece of metal that goes on the end of the femoral bone. And so we basically make small slices of bone in order to put that femoral component on. The red arrow is the tibial component. The tibial component consists of a flat tray of metal that sits on top of the tibial bone and then has what's called a keel that sits inside the bone. And we prepare that and put that on top of the tibia. The tibial cut is, excuse me, a flat cut. In between those two pieces goes the blue, the darker blue arrow, which is what's called polyethylene, which is a fancy plastic. That is a material that goes in between the femur and the tibia and really acts to increase the stability of the knee joint and is a low friction surface that femur rubs on through revolutions. This has been engineered over time to be better and better, and things like wear rates of that plastic over time have decreased with modernization of techniques to the point that knee replacements last an incredibly long time at this time. So let's discuss what I do when I replace a knee. It's really simple in theory, actually. I always tell people it's really not too hard to replace a knee, but it's really an art and a challenge to make each one as perfect as possible. Everybody's knee is a little bit different. People have different deformities, different angles of contractures, different soft tissues. And so with every knee replacement, we're trying to resurface the bones, and that's kind of the simple part. The more complex part is balancing the soft tissues, making for a good outcome. We'll talk a little bit about what's called knee kinematics, which is really what separates, I think, mediocre knee replacements from good knee replacements. And that's a really complex topic. We'll kind of boil that down a little bit in later on. So first, the skin incision. Now this patient's incision looks a lot better than average, I will tell you that. This has to do with the way we treat the skin during and after surgery, but also how the patient heals in general. Some people heal with small scars and thin scars, and some people don't. But this person is 1 year out from her left knee replacement at the time we're getting ready to do her right knee. And her incision here goes between the yellow dots. So generally, smaller people get smaller incision, larger people get larger incisions. But for the most part, I think with good techniques and good closure, generally for me, which involves absorbable sutures and waterproof dressings with no staples or sutures to take out. I think patients do really well and have a nice cosmetic outcome. And then once we get through the skin, this is what we do. We need to get into the knee joint to resurface it, right? So we go around the kneecap and get into the knee joint. The knee is encapsulated, so there's a thick, strong capsule around the knee joint. That capsule needs to be opened up to get inside the knee joint. So we do that. We go inside the knee, through around the kneecap and get into the knee joint. And then from there, we make small cuts of slivers of bone, usually on the order of 2 to 10 millimeters in size, in order to contour the ends of the bones to accept the replacement components. So some people think we just lop the end of the bone off and put a gigantic piece of metal on there. That's actually not what we do. We make little small slivers of bone cuts and put these components in place to resurface the ends of the bone. So those little light green lines there represent the areas where we cut in order to take slivers of bone off in order to contour the bone to accept the replacement components. And this is what it looks like when we're done on an x-ray. So the metal is separated by the plastic. So the reason the pieces of metal don't touch is because that piece of plastic is in the middle and that piece of plastic is radiolucent, meaning you can't see it on an x-ray, but that plastic is in between those components. There's the femoral component on top, the tibial component down bottom. Most of these components will have what's called a locking mechanism, which is basically the way that the plastic inserts onto the tibia. So in this component, that space you see, instead of the tibial piece being completely flat on the top, that little part of a bright area, the metal on the top of the tibia, is the locking mechanism of that type of device. But you can see there's no more bone-on-bone contact. So as opposed to the other patient's knee on the right side on that x-ray, where you can see bone-on-bone contact on the inside, and a bow-legged knee and a knee that's really worn out cartilage-wise on the inside. Now this knee is straighter and the knee is replaced and no more bone-on-bone contact. And here's a partial knee replacement x-ray. So just the inside aspect of the knee joint is replaced. The outside aspect of the knee and the kneecap or patellofemoral joint is not altered. And so this is the most common partial knee replacement, which is just the inside aspect. And there's really three parts to the knee, so this helps kind of show you the three parts of the knee. You have that inside aspect of the knee, which is replaced with the partial knee on this patient, the outside aspect of the knee, which is untouched, and then the front, which you can't see on this x-ray, is the kneecap joint. So in a partial knee replacement of the inside aspect, just the inside aspect, only one of the three parts is replaced. On a total knee replacement, all three parts are replaced. And that's the difference between a partial and total knee from a x-ray standpoint. So let's talk about frequently asked questions with knee replacement, of which there's a lot. These are not all of them, not exhaustive, but at least hopefully this will give you an idea to answer some questions about knee replacement. So very common ones: how long will the knee replacement last? Knee replacement has been engineered over about 50 years. So knee replacement has gotten better and better and better. And there's a ton of misconceptions about how long knee replacement will last. Of course, it depends on what happens to a knee replacement. You can have short-term failures of knee replacements like any other surgery, things like falls and broken bones and infection, which can cause problems. But from a long-term survivorship standpoint, if you look at the 20-year survivorship of modern knee replacements, that survivorship is in about the mid 80%, which means that about 85, 87% of total knee replacements will survive at 20 years for a patient. And so that means that more are lasting longer than that, and some are lasting less. And so that's a general range of information that we can give people. So these things do generally last a long time. Patients ask if the replacement weighs more. Generally, the weight of the components is pretty similar to what we take out, so not a big change in weight with the components. Can you get arthritis in a knee replacement? No. You can get some inflammation of the joint lining. So things like gout you can get. Patients with rheumatoid arthritis can get inflammation of the joint lining, but the bone-on-bone contact is gone. So the most common indication, which is osteoarthritis, cannot happen in a totally replaced knee. And that's opposed to a partial knee where you can get arthritis in the rest of your knee because you still have part of the knee. But in a total knee replacement, you cannot get osteoarthritis in the joint. When you go through airport security, you do not need a card for a joint replacement. Everybody, TSA knows now that joint replacements are very common, and so generally people get x-rayed. You will generally set off a metal detector with a joint replacement, and so that will happen, but again, very common, and so usually not a big issue. Um, what materials are knee replacements made of? I showed you that model. The gray pieces on that model that's moving there are made of metal, usually cobalt chrome or titanium. And the plastic in between is called polyethylene, which is high molecular weight polyethylene, which is a fancy, uh, incredibly engineered modern plastic. Um, Another common question, do I still have my ligaments? So yes, so we really rely on ligaments to sustain the stability of a knee. And we'll talk about that a little bit with the knee kinematics talk that's coming up. So there are ligaments that surround the knee. In my talk looking at knee anatomy, you can kind of learn more about those things. But on the sides of the knee, there's a medial collateral ligament and a lateral collateral ligament. Those always stay intact and they provide side-to-side stability of the knee. In the middle of the knee, there's the ACL and the PCL, in which case the ACL goes away in all total knee replacements, and the PCL stays in most of the part of the total knee replacements that I do, but you can keep or take the PCL depending on what kind of components you're going to use, and that provides the front to back stability. But otherwise, the quadriceps tendon, the patellar tendon, the medial collateral ligament, the lateral collateral ligament, all those surrounding soft tissue structures we rely on for stability because we want that knee to act just like your normal knee, and so those ligaments stay intact. Are there any difference in terms of the type of knee replacements? Generally, there are a lot of different companies that make knee replacements. There are large manufacturers that make knee replacements that are sold at really high levels. So there's 3 or 4 companies that kind of make up the bulk of those companies. There's some smaller companies that are out there that make knee replacements that aren't as well known, that are kind of smaller volume makers. But in general, because knee replacement is such a common procedure, they are made by multiple different manufacturers. There's not really a massive difference in outcomes in different types of total knee replacements when you look at studies and literature, when you look at all of the companies' top models of knee replacement. So most companies' top models do well and the results are reasonably equivalent. And really what separates the differentiation of what we use is what we're comfortable with, what we think is a little bit better, what works best in our hands, and what we think provides the best outcome for patients. These little subtle things, which really have a lot to do with our training, for instance, what kind of implants we use when we were learning how to do knee replacement and what we're comfortable with, that we tend to feel like are best for people and best for us. And so that's kind of where most of us gravitate to. But there are different companies that make knee replacement parts. Custom knee replacements are something that people talk about. You can get things like preoperative MRIs or CT scans to look at bony anatomy to create custom knee replacements for people. The results of these have been fairly mediocre in studies, and so most people do not use these. They really have shown no benefit, and in fact, some unique issues with them. And so, for the most part, these tend to be uncommon and pretty low volume type procedures that are being done for with these type of components. So in general, without any advantage to this type of thing, it sounds good to people, which primarily becomes a large marketing aspect of it, but the actual outcomes of how patients do are not improved, and therefore most of us do not think that these are a great idea. And towards that regard, in terms of needing an MRI or CT scan before a knee replacement, this is a common question that patients have. generally we never need MRI or CT scans for a knee replacement because we can see the anatomy on an X-ray, and so we know everything about the bony anatomy based on the preoperative X-rays and also the soft tissue anatomy based on your exam, and therefore an MRI or CT scan is incredibly rare to need before a knee replacement because it just does not help us at all. Um, this was common time, kind of a longer time ago, but it's still not too uncommon a question, which is, are there knee replacements for men or women? There's really not any difference between knee replacements for men or women. Probably about 10 to 15 years ago, there was sort of a fad of knee replacements for men or women, claiming that the knee was different, and turned out that this really didn't really bear out in how patients did, and therefore this is a kind of a non-existent issue at this point. There's a lot of younger patients having joint replacement and specifically knee replacement. And so one common thing is that younger people really want to be active and ask about if there are higher performing implants for younger people. There, the answer to that question is kind of yes and no, I guess. There uh, are newer implants, especially newer plastic pieces in the middle that provide probably better stability, which I'll talk a little bit about in the kinematics talk. There's also things to think about in terms of survivorship with younger people, meaning that if you think about why a knee replacement might fail in the future, you think about the bonding between the bone and the implant, which can either be cemented or uncemented. And sometimes in younger people, we'll think about uncemented components to potentially increase survivorship. And this all has pros and cons. We really have to think about the risks, the benefits, and what's best for people in this regard. In terms of the actual performing nature, really, as we make advancements in knee replacement, there's really no reason that a low demand patient wouldn't want a higher performing implant. So really, knee replacement is made to be as high performing as you could possibly make it for any patient. And therefore, there really isn't a difference between high performing or low performing knee replacements because there's no reason to not use the highest available performing implant for anybody that we could possibly think of, even if they're not going to demand that out of it. So for that reason, there's not really a difference in the higher or lower demand. But the kinematic aspect that I'll talk about, I think, is what really differentiates the ability of younger people to be able to do more active things successfully without pain and without swelling. And that's really does have to do a little bit with the specific implant we choose and the stability we can get with that implant. So we'll talk about that in a little bit. Um, it's very common for people to wonder how the implant is connected to the bone. So knee replacements can be cemented or uncemented, and that's how they're connected to the bone. So I'll go over that here. So in this picture on the left is uncemented knee replacement from the front and the side. So those pieces of metal do not have anything between themselves and the bone. They have a porous surface of the metal that actually allows the bone to grow into them. That's called an uncemented knee replacement. So no cement exists between those. So uncemented knee replacements are a little bit newer than cemented knee replacements. Cemented knee replacements are really the gold standard of knee replacements and have the longest track record and best survivorship. But uncemented knee replacements have gotten better and better, especially over the past 10 to 15 years, such that the results of uncemented knee replacements are now very good and seem to be almost equivalent to cemented knee replacements. The benefit of an uncemented knee replacement would be that if biologic ingrowth of bone into the implant is achieved, then potentially the longevity or survivorship of the implant could be longer. And so that's one thing we think about with the bonding between the implants. Otherwise, you can see on the image on the right that cloudy white stuff that green arrow points to is the cement at the junction between the implant and the bone. And so that's kind of like a grout material that goes between the implant and the bone and allows for fixation of the implant. And that's immediately stable and very good fixation. Again, that's the gold standard for knee replacement, of which all other sort of bonding options, including uncemented knees, kind of have to get to in order to really decide whether or not uncemented knees, for instance, are superior. But those are the two options for uncemented versus cemented knee replacement. We talked a little bit about partial versus total knee replacement. So let's talk a little bit more about considerations of partial total knee replacement. What are some of the pros and cons of a partial total knee replacement? So Partial knee replacement is good for patients with isolated arthritis of mostly the inside aspect of the knee with preserved lateral sides and preserved kneecap joints. So that's really the most common situation from an x-ray standpoint. Usually that means the pain is isolated to the inside aspect of the knee. The patient has a mild bow-legged type knee arthritis. And then we also need to think about bone quality and age. So generally we think of partial knee replacements as a bridging type procedure, meaning that the likelihood of a possible future subsequent procedure is relatively high, for instance, if a patient is very young. And therefore, we hope to get some good life and good function out of the knee with a partial knee replacement, but we know that possibly in the future a total knee replacement could be required. So for that reason, for me, partial knee replacements are really good in younger active patients and older patients. So I mean patients between 40 and 65 and patients generally older than 80 something. And there's a little bit of gray area in there where we have discussions about pros and cons of partial versus total knee replacement. But for the most part, they're great for young patients where we know that we can give them some good pain relief, but that even with total knee replacement, a revision could be required in their lifetime, or for older patients where a less invasive surgery is lower risk, and we can get them through this with little to no pain and a good outcome, and that will likely survive them forever and take away their pain. So that tends to be the patients that we'll do partial knee replacements in. The pros of a partial knee replacement are the fact that it is a little bit smaller of a surgery, it's a little less invasive, it saves more bone for the future, so you can convert that to a total knee replacement with good results. It tends to feel more natural to people because we're not making the entire joint metal and plastic. So most patients would say it feels a little bit more natural. And those are sort of some of the pros. The cons of a partial knee replacement are the fact that you do have other parts of the knee still there. So there are still cartilage bearing surfaces of the knee, which can get arthritic. So you can get arthritis in other parts of a partial knee replacement. And if you look at the overall survivorship of partial knee replacement, the survivorship is a little bit less. So if you think about it, we're putting in smaller metal objects inside the knee, and the likelihood of component loosening or progression of arthritis is higher with a partial knee, to the point that survivorship at 20 years is a little bit less with a partial knee than a total knee. Um, and so that's kind of the thought process with partial and total knees. And again, you can see this total knee replacement where this entire knee is resurfaced. So let's talk about how long knees will last, what can happen to a knee stability and knee kinematics and balance. So really a bit of a complex topic, but it's one of my passions, and I think it's a kind of an interesting thing to think of. And I think it'll help you a little bit explain, what the differences and outcomes with knee replacement are, and kind of what separates bad versus good knee replacements. And it's one of the more technical aspects, but I think important, especially for younger active people, to think about. So what if you think about what bad things can happen to a knee replacement? You can fall and break your bones around the knee replacement, have a bone fracture. You can fracture the implant, which is incredibly unlikely, but the implant theoretically could fracture. You can wear out the plastic. You can have instability of the knee, which is ligamentous laxity, or a situation where the knee shucks around too much side to side or front to back, which causes pain and instability sensations. You can have a loosening of the components from the bone. The knee can get infected with bacteria. Um, and those are some of the things that can happen to knee replacements, all of which are relatively rare, thankfully, but they can happen. But symptomatic instability is one of the more difficult things to really understand and diagnose. But it is a leading cause for knee patients being unhappy with their knee. So it's kind of an interesting thing to understand. And I do see patients in the office all the time who have knee replacements somewhere else, and they don't like their knee. And it's very common to get told, well, it looks good on x-ray, everything looks good, but it doesn't feel good to the patient. And so we'll talk a little bit about that. Knee kinematics is what describes the way the knee moves during activity. So really what we want to do is to have the knee move naturally with good stability and motion, similar to the way your knee worked when it was perfect for you. So when you were younger and you did not have arthritis. But the knee is a really complex joint. It's a hinge with a lot of complex dynamics. So balancing knee ligaments through motion, allowing for appropriate stability for activity without restricting motion, is what we try to do in every knee replacement. So what it can happen is if your knee replacement stability is not good enough for your activities, you might not like it. It might be painful and it could swell up, and therefore you won't like it with activities, or it won't function well with activities. So to combat this, we balance ligaments during the surgery, and we also use implants engineered to provide stability. Knee kinematics is one of my interests, and I have been involved in the engineering of knee replacement improvement. So, for instance, I worked on an international design team to develop a polyethylene component that aids stability between the femur and the tibia. So that's that picture of that plastic there. That's what's called a medial stabilized polyethylene. So it's a piece of plastic that's engineered to increase the front to back stability of the knee joint by creating a concave surface on the inside aspect. So it's kind of a bit of a technical thing, but that's something that I did with Johnson & Johnson, and we use that as an adjunct to stability along with their knee replacement components. And so that was a fun project to work with international experts to really try to figure out ways to improve currently well-functioning knee system, but to make it even better, especially in higher demand patients and patients that are really desiring more activity out of their joint replacements. So really, we're constantly working to make knees better and better. And after 50 years of engineering, knee replacements are very good overall. Not perfect. We are still going and still have ways to go to make these things even better. But in general, knee replacements are good with good long-term survivorship and a good ability to get rid of knee pain for patients with severe arthritis. So hopefully this helped and you learned some things about knee replacement, knee arthritis, and options for that. So thank you very much.